Mycosis fungoides has nothing to do with a fungal infection. In fact, it is a form of cutaneous T-cell lymphoma, and you get atypical lymphocytes which can be seen in the epidermis and dermis. And usually it has a very low-grade clinical course, and it can remain in one stage, so either patch, plaque, or tumor stage for a number of years. Now, initially, it presents as a pruritic eczematous type rash, which is in its pre-malignant stage. And oftentimes, if you look at the surface, it appears thinned, and you get this thing called cigarette paper atrophy. Now, I can't really appreciate that here, to tell the truth. But over time, the lesion slowly progresses to a thick plaque. So, as the lymphocytes infiltrate more and more, it goes from patch to plaque to thick tumor. And as the malignancy develops, you get nodular lesions appearing, and sometimes these can proceed to become necrotic. So here's an example of the patch stage where it looks like an eczematous patch that would be very itchy. Then it moves on as the lymphocytes invade more to the thicker plaque stage. And sometimes you can have multiple lesions, and then it moves on with more infiltration into this tumor stage where you get thick nodules, which can become necrotic. Now, with regards to treatment, as I said, it's usually got a very slow clinical course. It's almost impossible to actually get rid of the tumor, but you can keep it at bay. Topical steroids or light treatment might be quite beneficial, so UVB or PUVA can help here. But as the tumor progresses, you might then need to move on to other things such as chemotherapy or radiotherapy or other options that exist. Now moving on to Kaposi sarcoma, and the name is quite misleading. It's actually not it's not a neoplastic lesion at all. It's associated with human herpes virus 8, and it's a reactive hyperplasia of the vascular endothelial cells. So basically, these get thicker and bigger, and you get these kind of blue, red, purple kind of firm, warty lesions that can be quite striking in appearance, and they don't tend to be painful or itchy. Now, they, of course, with the AIDS epidemic and before kind of harsh treatment, they were quite common to be seen in young HIV positive men who were going on to have AIDS. And the lesions tend to be found on the tip of the nose, the neck, and buccal mucosa. But this lesion did exist prior to the AIDS epidemic, and it used to kind of, the classic case would be rare tumor of elderly men, which would affect the legs. It was often associated with lymphedema. Pityriasis rosea, it's most likely due to a virus, and it's the first clinical lesion you usually see is a Herald patch, and this is a isolated erythematous patch that is often seen kind of on the trunk, and this might be present for a period of time, and then after that you get these number of kind of oval macules and plaques appearing. Now, they often appear kind of along the pattern of the rib cage, and it's often described as in a fir tree pattern, as can be seen here, and they're usually annular to oval shaped. You don't really get involvement of the hands, feet, or scalp. So again, as we mentioned earlier, syphilis can affect the palms and soles of the feet. So that'll be in the differential. But here you don't really get involvement of the hands and feet. It's usually just more of a cosmetic concern for patients. They don't tend to get bad itch, and thankfully it tends to remit usually within 4 to 8 weeks. And for some reason, it's more common in spring and autumn. I'm not really sure why. And there's no specific treatment. You can give them antihistamines, maybe for itch. You can give them moisturizers. You may give them a weak to moderate topical steroid if they are very itchy, but it doesn't really shorten the duration of the disease or anything like that. Now we'll move on to scabies, and I suppose the main thing about scabies and picking it up is it's always scabies until proven otherwise. If a group of family members or a group of close contacts all develop an itchy rash, and it's due to the parasitic mite Sarcoptes scabiei, and it tends to present with these itchy kind of excoriated papules, and the main areas you see them are on the finger webs, on the wrists, on the ankles. The axilla is another area, and the genitalia, and are out kind of around the areola of the nipple as well. But they can be anywhere and can be really widespread. You can sometimes see burrows of the scabies mite, and this is basically the tracks of where the scabies mite has been passing through. I think I've got an example of it here. Yeah, so often if you look, which dermatologists have a dermatoscope, and they can look in and they often see these burrows, and this is the mite that has been tracking through. You often get a secondary kind of almost an allergic type eczematous rash that can occur around the area as well. You can often get nodules, which is kind of due to a hypersensitivity reaction. And I don't have an image of it here, but you often get these nodules in adult males, kind of around the genitalial area. And infants can get nodules on the palms or soles of the feet, which is another kind of telltale sign of scabies. Treatment is you use Lyclear or permethrin cream, and for in adults you use it from the neck down to everywhere at day 0 and day 7. In infants, it can actually occur on the face and scalp as well, so you might need to cover them completely. You should all close contact should be treated with this. You should wash all kind of bedding and clothing at a high heat, and take other measures like that as well. So here is just kind of the fissured areas and the papules that we see with scabies in the finger webs. Here's the wrist affected, and here are the burrows that I mentioned. So erythroderma stands for basically any inflammatory skin disorder covering an excess of 90% of the body. In adults, the commonest causes are eczema, then it's followed by psoriasis. I'd say drugs are more common than leukemia or lymphoma, but leukemia and lymphoma can cause it as well. And then sometimes different conditions, for example, a thing called pityriasis rubra pilaris, which we won't go into. But I suppose it can be acute or it can be chronic in patients, and it can cause a number of complications which you need to consider. So it can cause output cardiac failure. You can get hypothermia, and you can get loss of fluid and protein, which can damage their electrolytes as well, and it leads them to increased susceptibility for infection. So if it's acute, and the patient's unwell, you might need to keep them in, and make sure that they're maintaining their fluid input output status, that they're well heated, and other things like that, looking out for infection and things like that. So this is just a case of an erythrodermic patient. You can kind of see his silvery scale there. I think that's a scale more than his veins, and that might be the telltale sign that this was due to psoriasis. So Behçet's is it's an autoimmune condition, and the classic triad that we see is recurrent oral ulcers, recurrent genital ulcers, and iritis as well. The iritis can cause blindness, and it can basically present as these recurrent oral ulcers or genital ulcers that can be, they can be quite severe and they can be quite painful. One interesting thing that it shows is a thing called pattergy, which basically an exaggerated an exaggerated response to trauma. So in this instance, you can develop pustules or even ulcers at sites of venipuncture. You can get many other features with Behçet's, so they can get fevers, they can get abdominal pains with diarrhea, they can get joint pains, and there's an association with thrombosis and pericarditis. And interestingly, HLA-B5 is associated with ocular disease, and HLA-B12 is associated with recurrent ulcers. Um, and it says here that treatment is with steroids or colchicine, but it probably is more complex than that. To tell you the truth, I haven't seen a lot of Behçet's. Another thing is reactive arthritis, and if you get the other classic features that I'll mention, it's called Reiter's syndrome. And this is an autoimmune reaction to an infectious agent. So it can be due to bacteria, so it can be due to chlamydia, it can be due to gastro things such as Campylobacter, Shigella, or Salmonella. And the classic triad is that you can't see, you can't pee, and you can't climb a tree. So you often get a non-supportive polyarthritis, which often affects the lower limbs more than the other areas. Then you can also get an inflammatory eye disease, in which you get a conjunctivitis, which may be followed by an iritis. And then you can get a urethritis, so you can get pain when passing urine and pus in that area as well. You can also get other things. So you can get skin lesions which occur on the feet with pustules and hyperkeratosis, and this is called keratoderma blenuragicum, and this is a really extreme variant. As you can see, there's thick hyperkeratosis, and there's probably lots of pustules there as well that you could see if you look closely. You can also get an erosive lesion affecting the penis or the mouth, and this is if it's affecting the penis, it's called circinate balanitis. And rare complications of reactive arthritis are problems with the heart, such as heart block, aortic incompetence, and pericarditis. Now go on to discuss different things that can cause change in pigment in the skin. Oftentimes, hyperpigmentation is seen in patients, and this can often just be due to a prior inflammatory condition that was happened there. So, one of the commonest causes of pigmentation is post-inflammatory hyperpigmentation, which I haven't mentioned otherwise in this site. But melasma is something that often occurs in women of childbearing age. It's a hormonally stimulated increase in melanin pigment that mainly appears on the face. So it's due to hormones, and in fact, melanocyte stimulating hormone levels are normal. And it tends to affect women who are pregnant or women who are taking the oral contraceptive pill. And you can get this hyperpigmentation, which can be quite striking and cause the patient a lot of concern. And it's often augmented by sunlight as well. If it happens in a pregnant woman, it can take many months to resolve after delivery, and it tends to affect women with darker skin tones, and it tends to be a lot worse of a problem in patients with darker skin tones. Um, so there's an image of the hyperpigmentation affecting the forehead and the cheeks and the tip of the nose. So I probably should have talked about morphea in the systemic sclerosis section, but it's actually different. It is a type of localized scleroderma, but thankfully it doesn't affect any other organs. And you tend to get these firm, white, or violaceous, so kind of purpley patches of thickened skin, which can occur on any body site. Typical areas are the thighs, the trunk, and the upper arms. And it tends to affect kids and young adults. And when the lesion is developing now, I'm not sure if you can really appreciate it here, but you often get this well demarcated red or violet peripheral edge, and this means that the lesion is still active. And then as the activity burns out, it tends to the edge tends to assume the same color as the central lesion. It often kind of then turns browny in color, and it can be very firm with an almost atrophic type glazed kind of appearance on the surface. There's a variant of morphea that is often seen in kids, where it's on the scalp and face, and this is called oncupta sab, and I think that means something about a blade anyway. So it can often look like a blade has been put down on this. So this is a young girl, poor girl, who has quite a striking morphea that is in a linear pattern on the forehead, and this is oncupta sab. So I'll move on to vitiligo, which is an autoimmune condition, and basically it's due to an autoimmune attack against melanocytes. So the melanocytes can be completely lost, and as a result, you get areas of skin depigmentation. And here's quite a striking variant. See in the middle, there's absolutely no pigmentation at all in some areas. And sometimes you can get regain of function, and the fact that there's little patches of brown within this might suggest that he's getting areas of repigmentation, but still, it is quite striking here. It's associated with lots of autoimmune things such as type 1 diabetes, celiac disease, autoimmune thyroid disease, and Addison's. And if you do a biopsy, you'll get a loss of the epidermal melanocytes, which are usually reside in the basal layer of the epidermis. You won't see these. Treatment's generally unsatisfactory. Unfortunately, there's no great treatment at all, and the condition occurs in darker skinned races. And of course, again, if it does affect these darker skin types, it can be quite striking and quite difficult for the patient. Now move on to albinism, and it's a group of inherited abnormalities of melanin synthesis. So it's reduced by congenital reduction or absence of the melanin pigment. And as a result, you can also get problems with developmental changes in the optic system, which results from this hypopigmentation within the eye. And patients, of course, are at increased risk of skin cancers due to the lack of protective pigment. And here's a poor woman who's got albinism. She's obviously of African descent, and she's got no pigment, and she's growing these quite nasty tumors as a result. So oculocutaneous albinism can affect two regions of the body, the skin and hair, and the optic system, including the eye and the optic nerves. But you can also get a variant called ocular albinism, where just the optic system is affected. Um, Now I'll just mention another thing in which pigment can look a bit off. It's called pityriasis versicolor. It's caused by a yeast called Malassezia furfur, and this is a normal commensal that is seen in everyone really, but for some reason it can cause a reaction in some people. If you get it in white on tan skin, you get these pale kind of brown or pink macules, which are scattered throughout the skin and are often hard to visualize. But then in tan skin or darker skin types, they will actually often look pale or white. And if you look closely at these hypopigmented areas, there'll actually be a fine scale to them. You diagnosis, you get out the trusty Woods light again, and it often shines a yellow-green fluorescence. And unfortunately, I don't have an image of that here. And then, if you take a biopsy and look at it under the microscope, you see hyphae and yeast cells, and this is often called the spaghetti and meatball pattern. So here are the yeast cells, and here are the hyphae. These are the meatballs, and these are the spaghetti. Treatment is often with just topical antifungals. If it's very severe, you might use oral antifungals, and the condition can recur. It tends to be worse in kind of humid environments, sweaty environments. This is when this tends to be a problem. Seborrheic dermatitis, again, it's caused by yeast. It's caused by Malassezia furfur again, and it's extremely common. You often get this kind of red, scaly area, which it often is found on the eyebrows, which I can't see here. It then kind of can go along the ridge of the nose here, and then the nasolabial folds is a real common area. And you've probably seen plenty of people that have seborrheic dermatitis. It tends to be more common and tends to be more severe in immunosuppressed patients, and also for some reason patients with neurological conditions. So it's often seen in people with Parkinson's. And again, you can treat with a topical antifungal. So you might use ketoconazole shampoo, which can be effective, or else you can use something like miconazole, or also known as Dactaren, and that will usually get rid of most cases. Now just last two topics are just genodermatoses, which are kind of the weird and wonderful things, but I think they can probably come up. So tuberous sclerosis, it's an autosomal dominant condition and with variable expression. Apart from the skin problems, you can often get epilepsy in infancy or childhood, and you can also get learning difficulties in patients as well. I don't know how politically correct that is, what I've said there. But with regards to skin changes, you can get these angiofibromas, which are just scattered tumors, and you can see quite a few of them here. They often do present in this area around the cheeks, over the nose, and on the face. You can often get this butterfly distribution. You can also get these things called periungual fibromas, which can often go up from the nail folds, and it's not really seen here, but there'll often be little very prominent pink nodules that can be seen when they're seen in paler skin types. You can also get a thing called a shagreen patch, which is basically just thickened thickened areas of kind of angiofibromas, which can be seen on the trunk, and they'll be leathery kind of in feel if you rub your finger along them. And then you can also get a Nash leaf macule, which is they're often elevated hypopigmented macules, and these are some examples of on the buttocks of someone of the ash leaf macule. You just mentioned here fundoscopy. I've never used fundoscopy, but it might reveal white streaks along the fundal vessels, whatever that means. And then finally, we'll move on to neurofibromatosis. And the type 1 tends to be the problem with all the skin. And you often get a mix of skin features. So here we can see really marked cutaneous neurofibromas. Oftentimes, when the patient is young, they won't have them, and then with age, they'll really progress. And this is really quite alarming, as you can see here. Often when they're the first signs you might see is just cafe au lait spots, so they're little kind of brown macules that can be scattered on the skin. They often say you need 6 or more kind of to be in keeping with the classification for diagnosis. You can also get axillary freckling, which is another sign you should definitely look out for. Um, and you can get these things called leash nodules. If you look on DermNet, there's a really good example, but there's often these multiple brown deposits which are quite striking and seen in the iris of the eye. You can also get optic nerve gliomas, which can cause problems with vision. Uh, as I said, these kind of cutaneous neurofibromas often develop over the years, and they can get worse actually during puberty and during pregnancy. And you can get many other features as well as the skin features in neurofibromatous type 1, including hypertension and learning difficulties or behavior problems. And then type 2, you don't tend to get as many skin features, but you get more CNS tumors, and acoustic neurofibromas in particular are common. And juvenile cataracts also are apparently quite common in type 2 neurofibromatosis. So these are all the topics that I will run through. There might be a few other things that come up, but as I said, I'll be grateful for any input or advice on things to add. Also, if anyone could email what questions do come up in the exams, I can add them in or tailor them to other ways. I might add some MCQs in the future if you think that would be relevant. But you've obviously got them on examination and past tests, so you probably don't need any more MCQs. Anyway, hope that was helpful, and any advice is greatly appreciated.